Very good evening to everyone and welcome to No Thrombosis program. No Thrombosis program is dedicated program, specifically for in-clinical discussion. We have two types of no thrombosis. One is interventional case. Interventional case we discuss on that. That is called diving box. And second, no thrombosis is the live workshop. So this workshop, specifically in this no thrombosis program, we discuss on real life challenging cases. That is, clinical cardiology, particularly related to patients with CAD, PAD, DVT, pulmonary embolism, and AF. So today, and also I want to inform everyone that no thrombosis program has received most engaging scientific platform by any pharma company from Sims Medica. And today is our post director, none other than Dr. Girish B. Navsundi sir. Dr. Girish Navsundi sir is director cath lab in senior interventional cardiologist from Apollo Hospital, Bangalore. Sir has performed over 4,000 angiogram through femoral and radial and ulnar approach, and about 1,600 angioplasties, both coronary and peripheral. Sir, sir is the first cardiologist to implant, absorbed stent in, private healthcare sector in the state of Karnataka. Sir is the first cardiologist to implant MRI compatible AICD system in the state of Karnataka. Sir is the first cardiologist to implant, tempering coronary stent in the state of Karnataka. So from behalf of MCure, I welcome to Dr. Girish sir for our no thrombosis program. And today's our first course moderator is Dr. Vinod Kumar Balakrishnan. Dr. Vinod Kumar Balakrishnan is Associate Professor and Consultant Cardiologist, Department of Dr. Vinod Kumar Balakrishnan is Associate Professor and Consultant Cardiologist in Department of Cardiologist at Sri Ramchandra University, Chennai. Sir has participated in many national and international conferences as a faculty. Is also participated in many clinical trials as a principal investigator. So from behalf of MCure, I welcome to Dr. Vinod Kumar Balakrishnan for our today's no thrombosis program.
Thank you.
Yes, sir. And today's our first speaker is Dr. Abhishek Kasha. Dr. Abhishek Kasha is a very, he is from Chennai. He has done MD in internal medicine and he's a gold medalist, and he's also a doctor in NB cardiologist. He's an interventional cardiologist and associate consultant from Apollo Min Hospital, Chennai. Sir has, published more than 10 articles in different national and international journals, and also received many, femoral awards specifically in the field of cardiologist. So from behalf of MCure, I welcome to Dr. Abhishek Kasha for our today's no thrombosis program. Our next case presenter is Dr. Murli Krishna. Dr. Murli Krishna is, MS General Surgeon and DNB in Vascular Surgeon. He's also done FEES as a fellowship. He's a professor and HOD of Vascular Surgery, Sri Jayadeva Institute of Cardiovascular Science and Research, Bangalore. Sir has performed, there are numerous, specifically in peripheral artery disease and vascular surgery, specifically, and he's also have more than 15 years of experience in the field of, vascular surgeon. So from behalf of MCure, I welcome to Dr. Murli Krishnan for our today's program. So today's our objective, our agenda is that, specifically we are discussing on in-clinical cases. There are two cases we have specifically. One is, the vascular dose in peripheral artery disease management. That case will be presented by Dr. Murli Krishnan. He will be presenting as a first case. And second case will be presented by Dr. Abhishek Kasha. He is going to present on unique case on AF and stroke prevention. So with this, I will hand over this session, the program sessions to Dr. Girish Navsundi, sir. Over to you, Girish, sir.
Thank you, Dr. Ravi. And as usual, you have been MCure has been the champion of thrombosis and, in a varied subsets in peripheral vascular, central nervous system, coronary, splenic circulations, pericardial. I think there are no case discussion that we have not had involving cardiovascular system and also beyond that. And today we have one of my dear friends. It's nice to know Dr. Murli is on board today as a vascular surgeon as well as an endovascular interventionalist. He does very high quality work and he's got an interesting case to discuss. And we have another good, young colleague of ours from Chennai Main Apollo. I think we should have a good discussion once they present. I look forward to this meeting.
Thank you, sir.
So if you could say.
Yeah. Sir, shall we go ahead with the session, sir? Probably then we can have the discussion.
Yeah, please start.
So the first speaker can start in presenting the case. Sir?
Yeah.
Yeah, sure.
Can you share the screen? Play the video. Sorry, I could not get the PowerPoint due to unscheduled emergency. I could not go home. So my colleague has made it as a video because of the file. Please pause here. So this is an interesting case. Am I audible?
Yes, Dr. Murli.
Yeah, she's a 75-year-old lady, diabetic, hypertensive, and ischemic heart disease with a past history of COX. And she came with a history of pain in the left foot for about 2 weeks duration. So that time the toes were not this obviously gangrenous. So, and that was the MR picture. So since it was acute, she also gave a history of claudication pain in the past. So that was suggesting acute and chronic ischemic component. If you observe the angiogram on the right, so on the right side of the PowerPoint, so the left lower limb is the index. You can see there is a cutoff in the popliteal artery, and distally you can see the twig of anterior tibial artery up to the mid leg, and then posterior tibial artery is reformed and seen only up to above the ankle level, and there is absolutely no outflow in the foot. In view of this poor outflow, I managed it conservatively for about 2 weeks with anticoagulation of enoxaparin therapeutic dose of about 60 milligram twice daily. She did improve initially, but later on she started deteriorating in terms of toe discoloration. So you can see that gangrenous spot that was about after 2 weeks of anticoagulation. So that is when we decided to intervene. And the plan was, 1 second, sir, sorry. Sorry, sir. I'm sorry. Am I audible?
Yes, sir.
Am I audible, sir? Girish, sir?
Yes, sir. Yes, sir. Yes, sir. You're audible, sir. Yes, sir.
Yes, Dr. Murli, you are clearly audible.
Yes, sir. So our plan was to, because we are not sure whether the popliteal was, we had a suspicion that it is acute and chronic based on the history, but we were not sure what approach to go. So our plan was to go from the femoral antegrade approach, left common femoral antegrade approach, and do an angiogram and decide the further course of action. So play the video. And on the angio, you can see here, left superficial femoral artery is nicely opacified. And there is a crescent-shaped defect at about 8 centimeter level. And the popliteal is completely cut off. And there is a faint reformation of the anterior tibial artery. Pause. So with this, the guide wire test was also positive. I could pass the guide wire easily. That confirmed it as a acute component in the popliteal segment. So what I did is I went to the transpopliteal approach. Distal popliteal was exposed below the knee and took control of anterior tibial and tibioperoneal trunk and did a thrombectomy. And you could see the previous slide that there was a thrombus that was taken out. Now play again. After the thrombus was taken out and we came with the catheter, and you can see the anterior tibial artery is reformed. This is the layered thrombus, you can see. We did a thrombectomy again. And there was some chronic component also. For that, we did popliteal angioplasty using a 5x120 balloon. This is the angio image, completion angio image. You can see nice popliteal seen up to popliteal bifurcation. Since the outflow was poor beyond the ankle, we passed a guide wire, and with the 2.5 into 120, we did an angioplasty of the common plantar artery and distal posterior tibial also. Angioplasty continuing in the posterior tibial artery. And this is the angio after transpopliteal thrombectomy. Pause here. Can you come back for a few? Yeah, a little bit. Yeah, you play here. Pause here. Pause. Okay, can you show me? No, you are going back. You move the cursor to the pause button. Pause.
There's some
Play again and pause the image. Yeah, pause. You're missing it. It's okay. Yeah. So this is the angio. Pause here. This is the angio image after the transpopliteal thrombectomy and retrograde thrombectomy and distal thrombectomy and removal of the thrombus and angioplasting of the popliteal and tibioperoneal trunk. I could not pass the Fogarty to the tibioperoneal trunk. You can see the haziness in the tibioperoneal trunk area. The contrast extravasation is from the arteriotomy incision, which I had not closed. I just approximated the sutures. I was doing the intervention from femoral, left common femoral antegrade. And if the thrombus size need to be taken out, then I was loosening the sutures from the distal popliteal and doing a Fogarty. So this was the angio, and since the posterior tibial artery was the one which was crossing the ankle, we desperately wanted to establish the flow. So despite repeated balloon dilatations, it remained haziness like this. And since this was a desperate attempt, what we did was we passed the guide wire and used the coronary stents. This is only second play please. Normally, we don't stent the infrapopliteal segment. This is only the second case in the last 12 years of my independent practice. I had done a stenting of the infrapopliteal segment. So in this case, I used a coronary stent to plaster that thrombotic segment. This is the coronary stents in the proximal tibioperoneal trunk and proximal posterior tibial artery. Post dilatation. This is the completion angio. You can see nicely opacified posterior tibial artery all the way to the ankle, but at the ankle it was still not that great. So we passed the 1-4 guide wire again, command wire, and inflated with Boston coyote balloon of 2.5 into 120, and redid the angioplasty of the common plantar and posterior tibial artery. This is the final shoot. You can see nice vessel crossing the ankle. This is the common plantar artery and foot arch is seen. So foot was salvaged. So this emphasizes that, you have in a chronic ischemia, you can do subintimal angioplasty and other things. In acute ischemia, you can do embolectomy or thrombolysis. But this is acute and chronic ischemia somewhere is where you need a hybrid approach. You need the skills of open and endovascular to get the maximum outcome. If I do thrombolysis for this case, this is little age thrombus. It wouldn't have lysed. If I pass a Fogarty, I couldn't have been able to pass the Fogarty all the way to the ankle. So this needed that hybrid approach, which we could salvage the limb. That's what I want to emphasize. Thank you, sir. That's the end of my presentation.
Thank you, Dr. Murali. I think it's an excellent demonstration. I just wanted to ask you, from the popliteal, you are withdrawing the clots, is it?
Yes, sir.
Retrogradely as well as antegradely?
Yes, sir. Yes, sir.
So you'll
So
go
what-
down to
Yes, sir. What we do
tibia?
is we make a transverse arteriotomy. Because if we do vertical arteriotomy, you have to patch. Otherwise, if we make transverse arteriotomy, we can close primarily with the Prolin sutures. See, of the circumference of the artery, we make about 1/3 of the cut. So, and use 4 Fogarty, it will be like a Foley. So you go retrogradely into all the way to the proximal superficial femoral artery. In this case, I went only up to the mid-thigh level because up to that point it was normal. And distally, when I tried to pass a number 4 Fogarty, the anterior tibial was going to the mid-leg, but tibioperoneal trunk was not negotiating that well. That's when I came from above and crossed the wire and then did an angioplasty of that.
Angioplasty. Yes. I think it's great. Apart from thrombus, maybe there was some amount of dissection because stent not only covers just the thrombus, but also it seals the dissections that are either caused by, and you had a fabulous result. And in the future, if you really consider, now we have these dissolvable scaffolds or stents.
Correct.
If you really think, you don't want to leave something permanently, you can use. Merrill has this Mirus 100.
Okay.
So you can
What's
consider
the cost,
it 1 lakh.
1 lakh.
So if you think it's a delicate region where you don't want to leave behind something permanent, it starts disintegrating in about 6 months.
Okay.
In about 1 year and 3, everything gets dissolved.
Okay.
So apart from it, what was the cause? Why did from where did the clot come down here?
In
de novo
this case,
or some embolization?
De novo, sir, because she did not, her echo was fine, there was no source of emboli, and angio did not show any arterial source of emboli. It was the de novo thrombus.
And what is her anticoagulation subsequently now that it's been done?
I have managed her with lomal enoxaparin only for the subsequent 3 weeks. After that, I switched on to rivaroxaban.
How much of rivaroxaban?
20 milligrams once daily, sir. BID dose in this patient, because she's a de novo thrombus lady, I did not want to take a chance. So I'm planning to continue therapeutic dose of rivaroxaban of 20 milligrams, like how we treat for DVT, once daily dosage, along with antiplatelets and silastazole. And maybe 1 year down the lane, I will switch over to dual antiplatelets or single antiplatelet with 2.5 mg BD rivaroxaban.
Now, this is, for my understanding, how long do you give anticoagulation such as rivaroxaban on an arterial side?
In an arterial side, see, it depends on the cause, sir. If you have an obvious identifiable cause and that is tackled, then it's fine. In this case, it's a de novo thrombus. We don't know whether it's a hypercoagulable state and other things. So unless you work up for that and then, chase, and hypercoagulable state is positive in only about 30% of the patients having a hypercoagulable state. The test is positive. So we don't know. That's why this arterial dose of dual pathway inhibitor concept has come. And, in the long term, till the limb is totally salvaged and the tissue loss is healed, we would like to continue on the therapeutic dose. And after that, you can switch over to this dual pathway inhibitor dose of 2.5 BD.
This rivaroxaban full dose. Rivaroxaban full dose along with how many? Single antiplatelet or dual antiplatelet?
Single antiplatelet, sir.
What do you prefer, aspirin, clopidogrel?
Aspirin, because it is cheaper. And one of the best.
Okay.
And one of the best also.
Fantastic. Yes. Yeah, very true. Very well established. Only thing is GI bleed is something that we are concerned when we give aspirin. Otherwise, it's a very well established antiplatelet. I think excellent. I'm very convinced about the method and greatly salvaged. What happened to the toe subsequently?
No, the toe I had to amputate, sir. But great toe I had to amputate. Rest of the toes salvaged.
Salvaged. Fantastic.
Yeah. Yes.
Excellent.
Thank you, sir.
Thanks for your time. Any other questions for Dr. Murli, please? Can I, Dr. Vinod, do you have
Yeah.
Any other
It's a
questions?
well-managed case, sir, absolutely. And whether this 2.5 mg with peripheral vascular disease along with when they are continuing after 1 year, whether they still prefer aspirin or they go with clopidogrel, sir, in your centers?
No, I work with a subset. I work in the government sector, subset of patients where they are relatively poor category, and somehow I always like aspirin more than clopidogrel, unless they have a gastritis or anything. Aspirin in combination with this one, rivaroxaban.
Oh, okay. Perfect. Probably we can move to the next case.
Any Holter or any ELR was done, sir?
I couldn't hear, sir.
He's asking whether any Holter was
Holter
done.
or ELR?
Holter was not done, sir. We got this one echo and even transesophageal echo also. We could not identify any cardiac source. And there was no any obvious AF kind of picture. Her heart rate and all was pretty much under control, but we didn't do Holter monitoring in that.
Okay.
Yes.
If it is the first and single episode, single vascular territory, if patients are, if not had the symptoms of arrhythmias, I think you're appropriate in not chasing. But if there's another episode or more than one vascular territory, I think atrial fibrillation could still be a possibility, because in most pulmonary embolism, you don't have a venous thrombus because in entirety it embolizes, not in part. So it's worthwhile to investigate.
We have taken our cardiology colleagues. We routinely take consultation from them for all our cases. So possibly in their workup they didn't suspect anything, maybe. Yes, sir.
Fantastic.
Yes, sir. Thank you, sir.
So then, thank you so much. You carry on with your work.
Yeah. Thank you, sir. Thank you so much. I'll have a case to start. I'll carry on. Thank you, sir.
Thank you, Murli, sir. Thank you so much, sir.
Thank you.
Thank you.
Thank you.
So can we have the next case?
Yes, sir. Good evening, sir. I am presenting, sir. I'll share my screens.
Thank you, Dr. Abhishek.
So good evening, one and all. Sir, here I am presenting a simple case of non-valvular atrial fibrillation presented with recurrent stroke. So here is my patient, a 67-year-old gentleman who is diabetic hypertensive, presented to emergency room with weakness of left upper limb and lower limb for the past 1 day with no history of seizure, loss of consciousness or sensory deficit, no prior history of heart disease, and he had history of TIA 1 year back with weakness of right upper limb and lower limb, which was not evaluated further. So he was conscious oriented to time place person, and his pulse was 82 per minute regular, and his blood pressure was 210 by 120, and his central nervous system examination, he has a GCS of 14 by 15, pupils bilateral equally reacting with no facial asymmetry, and power in left upper limb was 3 by 5 and lower limb was 2 by 5, and cardiac auscultation was uneventful, and RS was also fine, and all peripheral pulses were felt normally and no carotid brewing. So echo showed left atrial enlargement with left ventricular hypertrophy. His septal thickness was somewhere around 14 mm and no regional wall motion abnormality, and his LV function was normal with grade 1 diastolic dysfunction with normal filling pressures, no pulmonary hypertension, and no associated valvular lesions. So he was in medical ICU. He was called for, am I audible, sir? Hello?
Very much here. Please go ahead, doctor.
Yes, sir. Yes, sir. So patient was suggested for ELR by Holter. He was put on Holter the other day. So he was put in medical ICU and under neurocare. So Holter was put up on day 1 in medical ICU, and he was called for again a cardiac consultation in view of worsening neurological status. So then on our routine rounds, we found that the cardiac monitor was showing a irregular rhythm with heart rate of 140, and on the same time he was on ELR. So ELR was immediately taken out and sent for analysis on the day 2 itself, and it showed frequent episodes of atrial fibrillation with the fast ventricular rate. His Chartwa score was 3 and Hasbled was 3. So CT brain showed a few patchy areas of acute subacute infarct involving right parasagittal and frontoparietal region with the right parietal region as well. And MRI showed both MCA, ACA and PCA territory infarcts. And patient had bit of worsening neurological status. So repeat MRI showed the extending infarct area with hemorrhagic transformation. So patient was having atrial fibrillation with paroxysmal episodes. So once we started noticing atrial fibrillation, we started him on amiodarone infusion, and he was pharmacologically reverted to sinus rhythm. But what happened was he was having worsening neurological status requiring ventilatory support. Neurologist asked for an EEG, which showed some mild bilateral diffuse dysfunction. And even they did CSF analysis for worsening neurological status, does not reveal any abnormality, and his vasculitis workup was also uneventful. So it's a case of recurrent cardioembolic stroke, atrial fibrillation with fast ventricular rate, which was pharmacologically disordered with underlying history of diabetes and hypertension. So he was started on neuroprotectives, hypertension measures, and rhythm was controlled with amiodarone. Rate control measures were started. Parenteral anticoagulation was there, and he was discharged with novel anticoagulant, and he is in follow-up with residual neurological deficit. And now he is currently in sinus rhythm. That's the case, sir. I think we can discuss the case, sir.
Thank you, Dr. Abhishek. But I can summarize what was the clinical presentation, and how did you choose to decide on this drug? Why not some other class of DOAC?
Again, coming to his profile, sir, he had renal dysfunction. I didn't mention about the parameters. Initially, he had worsening urea and creatinine. So his urea was around 90, creat was around 2.1 initially. That time he was on heparin. Gradually, it improved, and his baseline creat at time of discharge was creat of 1.4 with urea of 50. I thought with EGFR somewhere around 6.
Hello? Hello.
Then probably we have lost him. I'm not sure. Abhishek?
Hello, sir.
Yeah.
Yeah.
Sir.
Sorry, we couldn't hear you. Come again.
Sir, there was worsening of his renal parameters. His urea and creat was on higher side during the course in ICU, and his creat was somewhere around 2.1, and the urea was around 90, which gradually improved. At the time of discharge, his baseline creat was 1.4 and urea was 60. So we thought apixaban is an ideal option, taking his EGFR into consideration.
Now, very well appropriate. I think this is how most times you need to titrate the anticoagulation. The first, start the parenteral. Maybe if many of the time, kidney is the enemy of the vascular system. It does not let you give the right dose of antithrombotic drugs, and then allows you problem in terms of contrast. And then to keep on a long term, you need to choose drugs who are renal safe. I think among the anticoagulants, we have learned that probably apixaban is relatively safer. Not that absolute, but relatively safer compared to other class of drugs. I concur with you. and how long you intend to give, and how do you diagnose atrial fibrillation on a Holter? That's again another question, isn't it? Was it
Yes,
a
sir. Actually, he
paroxysmal,
was on
persistent?
Holter,
What
but
was it like?
luckily what happened during our regular daily morning rounds, the cardiac monitor itself was showing irregular rhythm. Immediately ECG was taken, which I displayed in my slides, which was showing AF with
Correct.
FER.
Okay, fantastic. But there are clear definitions on Holter if you have to call somebody as an atrial fibrillation patient. If it is for a few seconds or just a minute, you don't brand them. You need a certain duration of continuous or over a period of 24 hours presence for a certain duration before you brand them as atrial fibrillation. Otherwise,
Actually,
many
I have gone through that
people
Holter
may have
report,
few
sir.
runs for a few seconds.
Actually, I have gone through that Holter
Yeah.
report, sir. It was done for some 16 hours, actually, because monitor itself has picked it. We removed the device out. So that was showing a
Fantastic.
duration of brief episodes of Holter AF almost for a duration of 60 minutes, 45 minutes. It
Oh.
was there, sir.
Then it's okay. That makes sense, because once you diagnose somebody to have atrial fibrillation, it becomes calculate the Chad-Vask risk score, and then you really need to give an adequate dose of anticoagulation. In this case, you gave apixaban. And what dose did you choose, and why did you choose that?
So again, I went by EGFR. His EGFR was somewhere around 60 and 70. So I thought then there's no need for dose reduction. He was a heavily built man. He was around 80 kilos. So I thought I will go for 5 mg. If his EGFR was somewhere less than 30, I would have opted for 2.5 milligrams of apixaban.
Yes.
You
I
have
think
to
if you
follow
have more
ABC
than
criteria.
2 of those characters, I think you will call them. Right. Could you elaborate on that, please?
Any age above 80 or weight less than 60 and creatinine is more than 1.5, probably any 2 of these criteria are satisfied. Otherwise, always apixaban is 5 mg twice daily.
Yes.
Yes, Abhishek, and that will be the right choice. So you are on appropriate dose of apixaban.
Yes.
Renal clearance of apixaban is just 25%. So obviously your choice goes very well with in a renal patient. Apixaban would be the ideal choice.
Yes, sir. Yes, sir.
Previous 2 episodes of strokes where patient was evaluated, Abhishek.
Sir, actually, that's the thing, sir. He was not evaluated properly. 2 episodes he was with GPs, and they told it as the TIA was completely was beaten in the bush, and they didn't evaluate. He didn't meet any cardiologist or a neurologist either. He was just taking hypertensives. His blood pressure was not under control. He developed hypertensive heart disease as well. I think hypertension is the cause for his stroke per se. Because he developed atrial fibrillation because he had concentric LVH. His LA was dilated, sir.
Okay. The thing is, a lot of times what happens with the GPs and CPs is, though they get diagnosed with AFib, a lot of times the patients are put on antiplatelets rather than anticoagulants. So putting them on a dual antiplatelet or single antiplatelet is much worse than not treating them, because you are going to ultimately increase the risk of bleeding without going to save the patients from AFib episode of stroke. That's the reason I wanted to ask you. The anticoagulation is introduction of anticoagulation to a patient with AFib is very, very much needed. And there is always a fear concept among physicians to introduce anticoagulation, though it is necessarily appropriate. A lot of time they are left with antiplatelets instead of anticoagulants, which are not going to help the patient to prevent a stroke episode. So in your case, it is well appropriately managed patient. So it's a good thing.
My doubt was now, sir, again, this patient presents to us with any further episodes of atrial fibrillation. I think we can opt them for radio frequency ablation.
Obviously.
Yeah, that's right.
Now we have multiple ways to go and do an EP RFA. Either we have cryo also available with us here, and even in our Apollo is there. No, so
Yes,
whenever there is a recurrence of AFib, the rate is not under control. If there is a recurrent event, then you can even go for pulmonary vein isolation. probably EP with RFA would be a appropriate choice.
Yes, sir. Yes, sir.
I think, yeah,
Sir.
excellent. How was the valves, Dr. Abhishek? I wanted to ask,
Sir.
was there any mitral valve disease, aortic valve disease?
No, sir. No, sir. I showed it.
Heart
in,
failure.
echo, sir. Actually, the slide I displayed, sir, there are no associated valvular lesions, sir.
Right. Okay. Okay. That's the that. Now that you have initiated on anticoagulation, he's reasonably protected against a stroke or a systemic embolization, but there'll still be residual risk. If it continues with another episode, you may also have to do imaging of the neuro system, neurovascular system, that is carotid, vertebral, to know is there any additional atherosclerosis too. We can't just call it embolic stroke because we had few atrial fibrillation episodes, because at
Actually,
that age
it was
they could
ruled
also
out in
have
this patient, sir.
atherosclerosis.
When they did an MRI, they did an MR neck vessels as well. And there was no any significant carotid disease as well.
Oh, fantastic. So that's a great relief. So I think it was a well diagnosed and concluded and therapy offered. Are there any other questions, Mr. Kesur, on the platform?
Sir, most of the questions we have covered, sir, in your discussions.
Okay.
Yes, sir.
I think it was a brief case presentation, but that is the ideal way to manage. As we said, we have 3 available DOACs in India. Now all of them have gone out of patent, so everything is available with a Indian manufacturing. The competition is going to be more intense, and one good thing is availability of all 3 drugs is going to be easy. So now we'll have to choose the right drug for the right population. Probably in this case, you have been very apt, because very elderly, renal compromised patient, I think apixaban was a good choice. And in the previous case, as Dr. Murali Krishna showed, I think rivaroxaban 20 milligram full dose with an aspirin was also very, very good choice.
Yes.
Yeah. Thank you.
Thanks, sir.
If there are not many questions, I think we'll thank MCure and ask for their conclusion.
Sir, thank you, sir. Today I have a very good, fantastic 2 case presentation. One is by Dr. Abhishek, as well as one is Dr. Murali Krishna. And we had tried to cover the 2 things. One is that given vascular cases, and as well as the AF cases or DVT cases. So both the things we have covered today. And there is fantastic discussion. I'm very happy to inform all of you, sir, that almost 323 doctors they're attending today. Even today, the Dhanteras and Diwali starting, and still in this case, 323 doctors, specifically I can say all cardiologists and PG doctors we've invited, and they have joined today, and they have got a lot of benefit, I hope so, from this or today's discussion. And with this, I want to say thanks to our moderator, Dr. Vinod Kumar sir, and Dr. Girish Navsundini sir, as well as both the speakers. Thank you, sir. And once again, from behalf of MCure, wish you very, very, very happy Diwali, sir. And with this note, we'll close this program, sir. Thank you, sir. Good night.
Thank you. Good night.
Thank you. Good night.